Welcome to another episode of the CNS Neurosurgery 100 series. My name is Yinn Cher Ooi. I am a vascular neurosurgeon at Texas Health Harris Methodist at Fort Worth. Today, we will be discussing the treatment of cervical carotid artery disease. As we all know, stroke is one of the leading causes of death and disability in the United States based on CDC results, and carotid artery disease is one of the leading cause of ischemic strokes in general, accounting for up to 33% of ischemic strokes. For those of us who manage patients with ischemic strokes, the effects on patients' quality of life as well as their family members cannot be overemphasized, as it has a tendency to create a condition worse than death. Carotid artery disease has been known to cause ischemic strokes via several different mechanisms, the most often being the artery-on-artery emboli. Severe or critical stenosis can also cause hypoperfusion strokes in the watershed territory, especially during episodes of significant blood pressure fluctuations. Ischemic strokes can also occur if there's an abrupt occlusion of an ulcerated plaque. These are some angiographic representations of the three different mechanisms that we have discussed. Carotid artery disease in general can be broadly classified into symptomatic versus asymptomatic lesions, as well as based on the degree of stenosis. Symptomatic lesions can either present as amaurosis fugax, a transient ischemic attack, or true ischemic strokes with lasting neurologic deficits. The degree of stenosis is measured as mild, moderate, or severe, and while there are several different ways to measure a carotid stenosis, the most widely accepted is the NASCET criteria using the listed formula. Carotid artery stenosis can be measured indirectly by measuring flow velocities using a carotid ultrasound, or directly using a CTA, MRA, or a digital subtraction angiography, which is the gold standard. The American Heart Association has very clear guidelines on which patients should be screened for carotid artery disease. All symptomatic patients with a prior neurologic event should be screened for a carotid artery disease. Asymptomatic patients with a carotid bruit or evidence of systemic vascular disease, or two or more known atherosclerotic risk factors as listed, should also be screened for carotid artery disease. It's important to note that all patients with known carotid artery disease should undergo best medical management, and that typically involves an antiplatelet along with statins, as well as treatment of modifiable risk factors. Of note, in an acutely symptomatic patient, treatment of hypertension should be done gradually to avoid further aggravating causing hypotensive strokes. Statins typically has dual function. It serves by not only reducing LDL levels, but also helps to stabilize the carotid plaque as well. Antiplatelet treatment typically involves aspirin and dual antiplatelet using aspirin in combination with Plavix or any of the other variants has shown to decrease the risk of future ischemic strokes or events. However, has been associated with increased risk for hemorrhagic complications and is typically not used for long-term management. I wanted to briefly highlight this study published in the JVS in 2013, looking at asymptomatic patients, 900 carotids with moderate stenosis. All patients underwent best medical management, and the study found that while all atherosclerotic patients should undergo best medical therapy, not all plaques will stabilize, and approximately 50% of the patients eventually had progression of disease, either progression of the stenosis to severe stenosis or developing a neurologic event. And that leads us to our current understanding of the treatment principle or philosophy for carotid artery disease. Stroke prevention is better with best medical therapy for all patients and select revascularization for at-risk patients. But the question is, which patients should undergo carotid revascularization? Broadly speaking, all symptomatic patients with moderate to severe stenosis should undergo carotid revascularization, and asymptomatic patients with stenosis greater than 80% should be considered, especially in centers with high volume. Let's move on to discuss carotid endarterectomies, or CEA, which remains the gold standard for carotid revascularization. This is a major surgery, which typically involves a long incision anterior to the sternocleidomastoid muscle with dissection down the avascular plane to expose the cervical carotid artery widely. However, in the age of minimally invasive surgeries and procedures, the ultrasound can be used to localize the carotid bifurcation as well as the level of stenosis, and the incision can be planned based on the level identified, and it just allows customization for a much smaller incision. Know that the common facial vein is your friend. It helps you localize the carotid bifurcation. It's not infrequent for the facial vein to be very large and intimidating, but they can always be safely ligated and divided, and should be done so early to avoid a venous avulsion. The carotid exposure is typically done from a caudal to cranial direction, as this helps identify and protect the hypoglossal nerve from injury. Once the carotid artery is exposed, a carotid sinus block is typically done with lidocaine without epinephrine. Heparin bolus is typically given prior to proceeding with the arteriotomy, and a protomy can be given to reverse the effects of heparin once the clamps are removed, as that significantly reduces the risk of a postoperative hematoma. It is very important to understand the carotid artery clamping sequence. The name of the game is to prevent thromboembolic complications. The mnemonic that neurosurgeons typically like to memorize is ICE, starting with the internal carotid artery clamp. This is to prevent any debris or thromboembolus from being flushed into the intracranial circulation. Before completing the suture line, it is important to backbleed the internal carotid artery by temporarily releasing and replacing the ICA clamp. And this is followed by then forward bleeding the common carotid artery. This just allows any thrombus that's formed distal to the ICA clamp or proximal to the CCA clamp to be flushed out. Once you've done so, avoid then suctioning blood out of the carotid as you complete the suture line. This just minimizes the air bubbles within the carotid. Removing the clamp will be done in the reverse order of placing the clamp, or the mnemonic de-ice, starting with the external carotid artery followed by the common carotid artery, then waiting for a few seconds while allowing any potential debris, emboli, or air bubbles to be flushed into the ECA system, then releasing the ICA clamp. These are some photo representations of intraoperative photos from a CEA. Of note, it's really important to really inspect the intima after you've completed your endarterectomy to watch out for any leaflets or residual plaque, as that can cause an embolus prior to completing the suture. Once you're done with your endarterectomy, you want to do a watertight running suture and ensure good hemostasis before closure. Some important CEA surgical considerations is general anesthesia versus regional anesthesia. For the most part, this is provider preference. Regional anesthesia allows one to perform the neurochecks during the placement of the clamps. However, it does require an experienced provider and very good patient selection, as you need a very cooperative patient to undergo a procedure under regional anesthesia. For those of us who do a CEA under general anesthesia, we typically use neuromonitoring during clamp placement. If there's any EEG slowing or neuro exam change after clamp placement, that can be first be addressed by increasing the blood pressure. If that is not sufficient, then a carotid shunt can be used. In our institution, we do not routinely use carotid shunts, as it has been known to be associated with slightly increased risk for thromboembolic complications. The use of carotid patch remains highly debated. Studies have shown that it does decrease the long-term risk for restenosis, but does increase procedure time as well as clamp time, carotid clamp time. This is a list of some well-described CEA complications, notably being the cranial nerve injury, the most common being hypoglossal nerve injury, as we discussed earlier. Please note that postoperative hemorrhage is a surgical emergency in carotid endarterectomies and should be identified and addressed promptly, typically starting off with emergent intubation for airway protection and prompt return to the OR for re-exploration and repair of the arteriotomy site. Let's move on to discuss carotid angioplasty stenting, which is obviously a minimally invasive procedure with significant cosmetic advantage when compared to carotid endarterectomies. It typically involves a shorter procedure time with less general anesthesia and can also be done under moderate sedation with the right patient. Being a minimally invasive procedure, there's typically minimal downtime. It can be done transfemorally or transradially, and it has been associated with an overall lower periprocedural adverse events. Some important considerations for carotid angioplasty stenting is due to the placement of a stent in the carotid, patients need to be on dual antiplatelet at least 7 to 10 days prior to the procedure and at least 30 days post-stenting with some sort of long-term monotherapy. So you really need to select the right patients who will be able to take their medications reliably. While the use of embolic protection devices is largely considered standard of care at this point in time, it's important to note that there are no large randomized trials to prove their benefit. There are, however, a series of studies that have shown that EPDs do reduce periprocedural stroke risk when used by experienced providers. It's also important to note that the CMS actually does not reimburse carotid angioplasty stentings when an EPD is not used. The question of whether the procedure should be done transradial and transfemoral is really provider preference. The procedure can be safely done either way. However, there are certain arch anatomy that favor a transradial approach, such as a bovine arch for a left carotid. These are some intraprocedural images for a right carotid angioplasty stenting for a patient with symptomatic right ICA stenosis. You can see we've parked our long sheath in the distal common carotid artery, and the lesion has to be carefully traversed with the microwire to allow us to deploy the distal embolic protection device. In this case, we use a spider filter. The angioplasty is done after the filter has been deployed, and we typically allow the carotid to bleed back, or we even do manual aspiration as we deflate the balloon to further reduce the risk of embolic complication. And here you can see after the deployment of the stent, there's no clinically significant residual stenosis. I wanted to highlight the long-term data from the CREST study, which shows that carotid stents are durable, that there is no significant difference in post-procedural ipsilateral stroke or restenosis in the long term when compared with carotid endarterectomy. Here's a list of some well-described carotid angioplasty stenting complications. The most important complication to discuss with your patients are TIAs and strokes. Of note, if aggressive angioplasty stenting is done, post-stenting hypotension may occur, and we typically manage our patients immediately post-op in the ICU to monitor their blood pressure closely. This is a comparison when comparing transfemoral or transradial CAS with carotid endarterectomy as a minimally invasive procedure. Angioplasty stenting is typically associated with a lower periprocedural risk for adverse events, with a significantly lower risk for MI, as well as no significant risk for cranial nerve injury. However, transfemoral CAS is associated with an increased risk for periprocedural strokes, almost a twofold increase, 4.1% in CAS versus 2.3% in CEAs, based on the CREST data. And this is largely associated with the fact that prior to deploying the distal embolic protection device, one needs to traverse the aortic arch, as well as traverse the carotid plaque itself before the distal embolic protection device can be deployed. And those two steps have to be done with absolute care. And that leads us to our third option for carotid revascularization, as well as the newest option, which is a TCAR. One cannot discuss carotid revascularization these days without discussing TCAR, which stands for transcarotid artery revascularization. Think of TCAR as a hybrid procedure that combines the advantage of direct access with a surgical exposure, as well as the minimally invasive nature of angioplasty stenting. As we mentioned, it's a minimally invasive procedure. It avoids having to traverse the aortic arch, however, avoids a large cut down along the cranial nerve plexus, and utilizes flow reversal for neuroprotection. Transcarotid artery revascularization is done through a small linear incision made above the clavicle between the two heads of the sternocleidomastoid, typically about a 2-centimeter incision. Dissect down the avascular plane to the common carotid artery, which is circumferentially dissected. A pre-closure with a U-stitch is placed, and the artery is accessed with the en route sheath. And this is followed by contralateral femoral vein access. You can see here the ipsilateral carotid is accessed directly with the en route sheath, and the contralateral femoral vein is accessed, and the two systems are connected with a tubing with a filter, and this allows temporarily flow reversal, blood to flow from the carotid to the femoral vein during the angioplasty and stenting. Flow reversal typically takes about 7 to 15 minutes to allow the angioplasty stenting to be done. These are some intraprocedural images. You can see here we have our SCC retractor, or any standard ACDF retractor works as well. The en route sheath within the proximal common carotid artery. This patient had a symptomatic right ICA stenosis. And once you have arterial access, it becomes very similar to a standard angioplasty stenting. You can see here balloon angioplasty stenting, balloon angioplasty being done. The only notable difference is we do not have a distal embolic protection device, as we utilize flow reversal for protection against potential emboli. Here, the stent has been deployed, and there's no clinically significant residual stenosis. This is a photo of for this patient of the filter, which has successfully captured some of the potential emboli during the angioplasty. It's important to note that to date, there are no large-scale randomized trial comparing TCAR with CEA or CAS. However, there are studies that have studied TCAR itself, notably the Roadster trial, which looked into high surgical risk patients, which showed that the risk for periprocedural strokes is about 1.4%. This is compared with standard surgical risk patients in the CREST trial with 2.3% risk for stroke in CEA versus 4.1% in CAS. Now, looking at high surgical risk patients, there has been two studies now, the Roadster 1 and Roadster 2, looking at TCARs with the stroke risk of 1.4% and 0.6% respectively. Notably, there were a lot of lessons that were learned in Roadster 1 that was applied in the techniques done in Roadster 2. Equally important to point out is that Roadster 2 also involved new providers, not only a seasoned, experienced providers, and they were still able to achieve a low periprocedural stroke risk. And this is in comparison with a higher stroke risk compared to in CA patients and transfemoral CAS with high surgical risk patients. There's ongoing registry, the Society of Vascular Surgery registry that tracks patients undergoing TCAR-CA versus transfemoral CAS, and by far, TCARs have the lowest periprocedural stroke risk. Being a minimally invasive procedure, it has a much lower surgical morbidity when compared to CEA. Cosmetically speaking, it's a much smaller incision with minimal post-operative pain, and patients are typically able to be discharged the day after surgery. There's also a significantly lower risk for cranial nerve injury and MI. Having discussed the three different options for carotid revascularization, it all boils down to good patient selection. It's important to have surgical equipoise when it comes to the different options that we can offer our patients. However, there are general contraindications for intervention in general. Understand that a carotid revascularization is for stroke prevention and preservation of neurologic function. So if a patient is severely disabled with an MRS of 4 or 5, carotid revascularization is generally contraindicated. If there's chronic total occlusion, stenosis less than 50%, or in patients with just extremely high risk for periprocedural complications. There are important factors to take into consideration when deciding one technique versus the other, such as the level of the bifurcation and stenosis, the presence of contralateral occlusion, and prior surgery, plaque burden, as well as the vessel size. If there's one slide to take home from today's discussion, that would be this slide right here. In general, if you have a carotid lesion that is very high, above C2, or a high bifurcation, a hostile neck may be prior radiation, a patient who is immobile, unable to rotate their neck to the contralateral side, prior CEA or neck surgery. If there's a contralateral carotid occlusion, and if there is a really frail patient who's not going to tolerate a couple hours, 2 to 3 hours of general anesthesia, then generally a transfemoral CAS or a TCAR should be considered. However, in patients with low bifurcation where a CEA should be pretty straightforward, or if there is significant circumferential plaque calcification where an angioplasty stenting may not adequately open the carotid artery, or there's just significant risk for restenosis, or if there is significantly large or small ICA diameter where a stent may or may not be adequate, or if there's a hostile arch for carotid angioplasty stenting, namely a type 3 arch, and for TCARs, if there is significant proximal carotid CCA plaque where you do not want to access the carotid artery directly, then the advantage goes to carotid endarterectomy. So with that, I conclude the presentation for today, and I appreciate your attention.